Hi, welcome to today's educational session on lung cancer updates. I'm Eileen, one of the medical oncologists from the National Cancer Center. And thank you for joining us this morning. Um, LEAP, or rather Lung Cancer Education and Advocacy for Patients, is proud to present this um, session together with Dr. Aaron Tan. So Dr. Aaron Tan is a medical oncologist at the National Cancer Center also. He has completed his specialty training in medical oncology and his PhD in cancer drug discovery in the at the University of Sydney in 2011. He has since gone on to lead multiple clinical trials as well as studies to understand more about lung cancer and improve lung cancer outcomes. He has won several accolades in both the local as well as the international scene as a result of his work, and it's my greatest pleasure to invite Dr. Tan to share more about the latest advances in lung cancer, especially over the past year or so. What clinical trials are available at NCC? There will be a question and answer session at the end of this. So do post your questions that you have, and we'll do our very best to answer them. So, Aaron, please.
Thank you very much, Eileen, for the introduction. So, as mentioned, I'll be giving just some updates on lung cancer treatment and diagnosis, as well as clinical trials. So I thought I would also go through just some of the basics, in case we need that as a bit of background as well. So I'll start with this. This is actually a book cover, and I mean, I'm not sure if many patients, even clinicians, oncologists, may be aware of this book. It's called When Breath Becomes Air. It's actually a memoir written by the author is Paul Kalanithi. So Paul Kalanithi was actually a neurosurgeon in the United States, in the US. He was finishing his neurosurgery training, and unfortunately, he was actually diagnosed with stage 4 or metastatic lung cancer. This book actually came out just before I started my oncology training. So I read it during my training, and I think it's a good segue into lung cancer, and especially just trying to bridge that patient-doctor divide as well. And if anyone hasn't read the book, I would recommend that they read it. It's a compelling read. But it's actually interesting. This patient, I mean, this author had stage 4 lung cancer, but he actually had a certain subtype of lung cancer, EGFR mutated lung cancer, that we now know can be treated with targeted therapies. And I'll go through this in a little bit more detail, obviously, in some of my subsequent slides as well. So just a brief outline of what I will try and cover today. As I mentioned, I'll just give a very brief background on lung cancer, just to set the stage. Go through a little bit about diagnosis and some of the new technologies we have in terms of improving our ability to diagnose and select treatment. Just some brief updates on what treatment options we have available and some of the newer treatments and some of the new data. And of course, the clinical trials that we have available that here in NCCS as well. So just to start with a brief background on lung cancer. So what is lung cancer? Well, we can think of cancer as an uncontrolled growth of abnormal cells. And for lung cancer, these are obviously cells that may have started in the lungs. And here we can just see a figure here of a tumor in the lungs. And we can see that the classification here of non-small cell and small cell cancer, which again, I'll go into a little bit more detail on the next slide. But importantly, we need to understand that there are different subtypes of lung cancer. So how do we subtype lung cancer? Well, historically, it's actually been done just by looking under the microscope and looking at the appearance of the cancer cells under the microscope itself. And that's where this classification that many of you may be aware of small cell lung cancer and non-small cell lung cancer. And of course, small cell lung cancer is a slightly smaller proportion, around about 10 to 15% of lung cancer that is diagnosed in the purple, whereas the majority of lung cancer is what we call non-small cell lung cancer, which is around 80 to 85%. And of course, this is based purely just on the appearance under the microscope, as you may it may infer from the name. Small cell lung cancer cells look small; they're small, round cells under the microscope, and everything else is classified as non-small cell. But of course, as technology has evolved and as our understanding of cancer has evolved, we can further subtype lung cancer. And particularly for non-small cell lung cancer, there are, again, several different subtypes within non-small cell lung cancer. And predominantly, this is squamous cell carcinoma and adenocarcinoma. And essentially, these are types of non-small cell lung cancer that may be dependent on where the cancer had originated from and just the type of lung cells that the cancer originated from. But again, as we have evolved in terms of our understanding of cancer, we know that cancers are caused by mutations in the DNA. So just looking historically, in fact, 150 years ago, this is a picture of a Brazilian ophthalmologist who was actually the first to identify a family with hereditary retinoblastoma. This is an eye cancer that is caused by a hereditary mutation. And this is a picture of Watson and Crick, of course, the scientists who discovered the double helix model of DNA. But why is this particularly important for lung cancer? Well, again, as our understanding of lung cancer evolves, this changes our classification. This is just showing, again, the slide with the classification of small cell and non-small cell lung cancer. We further subtype non-small cell lung cancer generally into squamous and adenocarcinoma. But this is now evolving where in 2024, particularly in adenocarcinoma, we classify lung cancer by the presence of mutations in certain genes, and we call these oncogenic driver mutations. And essentially, these are mutations that have occurred in certain genes that are actually driving the cancer and have actually caused the cancer to grow and develop. And we can see in this pie chart here that, in fact, there is a bit of geographic variation. On the outer circle, we actually see the proportion of these driver mutations in Asian populations compared to the inner circle, where it's Western populations. And in particular, in the dark blue, we can see mutations in a gene we call EGFR, which represents up to around 50% of lung cancer in terms of adenocarcinoma in Asian populations. And this is compared to around 15 to 16% in Western populations. But we can also see, obviously, that there are a whole range of other driver mutations or driver alterations in other genes, such as KRAS. And in particular, there's a specific mutation, KRAS G12C. There are also alterations such as gene fusion mutations in a range of other genes listed there: ALK, ROS1, MET, HER2, BRAF, RET, and NTRK. And obviously, these are found in varying frequencies, but these are all important because now we have a much deeper classification of lung cancer. And of course, again, this is important because this influences what treatments we have and how we select treatments for patients. And it's this concept of precision oncology. So we know that if we detect these driver alterations in cancers, that we can potentially target them and obviously to treat the cancer as well. So historically, when we use treatments such as chemotherapy and we give them to a population of patients, we know that the treatment may not necessarily work in every patient. Some patients obviously may benefit and respond to the treatment. Some patients, it may not work. And potentially even in some patients, it may be harmful. But there is this concept of precision oncology where we want to give the right drug, obviously, to the right patient that we know will benefit from the treatment. And importantly, nowadays, it's about identifying the right target so that we can target, in particular, these driver oncogenic alterations for treatment. So here again, I just show the pie chart, which demonstrates, particularly for non-small cell lung cancer and adenocarcinoma, these oncogenic driver alterations that we now use to classify adenocarcinoma. But why is this important? Of course, we have treatments for each of these oncogenic driver alterations. And here we can see that there are, in fact, a whole range of drugs that are approved, both in the US and even here in Singapore, for the treatment of patients that may harbor these specific mutations. And I won't go through each drug, obviously, in detail, but just to demonstrate that the testing for this is important because we can now match patients to each of these therapies depending on whether the cancer harbors one of these oncogenic driver alterations. And here I'm just going to show a brief timeline of how things have evolved over time. So again, particularly looking over the past 5 years, 10 years, it started out with drugs that were approved for certain mutations and alterations in genes such as EGFR, ALK, ROS1, and BRAF. But over time, there have been numerous drugs that have been approved and are now potentially used as standard treatments for each of these alterations. But an expanding list with new drugs being approved almost on a monthly basis for different driver gene alterations. But I guess I just did want to emphasize as well that particularly in Asia, there is this geographical variation. And if you remember the author of the book that I showed in the first slide, he actually had EGFR mutated lung cancer, which is present in around 50 to 60% of patients in Asia and only around 10 to 15% in Western populations. And this is something that is obviously an area of research. We still don't really understand exactly why this occurs, much more prevalent in Asian populations, although there are a number of theories and potential hypotheses as to why this is the case. Having just set the stage that obviously there are these oncogenic driver alterations that we need to detect so that we can select the most appropriate treatments, how do we in fact diagnose lung cancer? So of course, when patients first present, they may have certain symptoms, there may be certain findings on physical examination, but we need to do a number of tests to be able to stage and diagnose the cancer. This may include various different studies, particularly looking at imaging studies such as CT scans, PET scans, MRI scans, to be able to see obviously where in the body the cancer may potentially be. But importantly, we do need to get a sample of the cancer to be able to obviously look under the microscope to diagnose the cancer itself, but also to get samples so that we can then test it to look for these particular mutations. And there, again, there are various different methods we can do this. There's potentially transthoracic needle biopsies, where we put a needle from the outside to get a sample. Potentially, it can be done through surgery, putting a camera in to also get a sample. Also bronchoscopy, where cameras put down into the airway to get a sample of the cancer as well. But again, as I've been alluding to, we now importantly want to test these samples for different mutations. And in particular, we have the ability to perform what we call multiplex testing now, where we test for all of these different mutations within a single test. And that's using a test called NGS, or next generation sequencing. We also, as a complementary test, do things such as IHC or immunohistochemistry, another form of testing called FISH. And essentially, these are just different methods that we use to be able to look for these mutations or alterations in these particular genes. But of course, we can see down the bottom here, there is also this emerging concept of liquid biopsy. So this is a fairly new technology, particularly in the past couple of years, maybe 5 years even, where in fact we know that the tumors can actually shed the DNA into the bloodstream. And when the tumor is shed, or the DNA is shed into the bloodstream, it's what we call cell-free DNA. These are fragments of DNA that may be in the bloodstream, you can see on the bottom left. But of course, it means that if we do a blood test, take a blood sample, potentially we can actually even test for these mutations just using a simple blood test. And again, this is using technology such as next generation sequencing to be able to look for these mutations in blood tests. And I'm sure potentially many patients here have, have had liquid biopsy done, and it is something that is starting to become used much more frequently in different situations for cancer. So now I'll just go through a little bit about treatment and just set the stage of what is our standard treatment and what are some of the new treatment options that we have available. So of course, cancer is complex. It may depend on the stage of the cancer, the type of lung cancer, the extent of the disease, the general health of the patient as to what treatment options and what treatments are recommended. But in general, we can generally classify treatments potentially such as local treatments, and these will be treatments that are targeted to specific spots of the cancer. So the options can include things like surgery, where we obviously can cut out the tumor, and potentially radiation treatment, where we can shine X-rays to treat the tumor with radiation. As a medical oncologist, our treatments that we prescribe are what we call systemic treatments. And so these are things such as chemotherapy that may potentially go through the bloodstream to try and go throughout the body wherever the cancer may be. Of course, historically, chemotherapy has been our standard treatment for many cancers. But again, in the past 5 to 10 years, there have been new treatments, as I've outlined, particularly the targeted therapies that target these certain mutations. But there's also these emerging therapies that we call immunotherapies that actually try to use the body's immune system to fight the cancer. I've gone through some of the targeted therapies already, but importantly, there is this broad class called immunotherapy where we actually try to use the body's own immune system to fight the cancer. And this is a cover from Time magazine. This is actually now from 25 years ago, where the targeted therapies were first being developed and the first approvals. This is actually a picture of a drug called imatinib, which was the first targeted therapy which was approved. But we can see that 25 years ago, this was really the hot sort of topic within cancer. These were sort of seen as the latest, and significant improvement in cancer treatment. But perhaps now 10 years ago, there was this significant breakthrough in what we call immunotherapy, where we actually use the body's own immune system to fight the cancer. And again, this is a broad class of treatments. There are a number of different drugs that we class as immunotherapies, really just demonstrating how we are improving our cancer treatments and how treatment is changing over time. But how does it actually work? So for lung cancer, perhaps the mainstay of immunotherapy treatments are what we call PD-1 or PD-L1 inhibitors. And these are drugs that potentially, again, many patients may have received. So how does it actually work? Well, this is obviously a small cartoon trying to demonstrate how it works. In the blue, this is actually a T cell, which is an immune cell, a cell that's within the immune system. In the pink, we have a cancer cell. And when patients have cancer, the T cell, may recognize cancer to try and remove the cancer. But cancers obviously can evolve and mutate, and they develop ways that they actually hide from the immune system, and they express certain markers that actually prevent the T cells from recognizing the cancer. So this is done by using sort of proteins such as PD-1 or PD-L1 on the cell surface of the cancer. So by using what we call PD-1 checkpoint blockade, by blocking this particular protein, it actually unmasks the tumor so that the immune system can then recognize the cancer again. So the cancers hide themselves from the immune system, but by giving treatment such as immunotherapy, we can unmask the tumor so that the immune system can then recognize the cancer again to obviously try and remove the cancer. So I'll just go through some of the basics in terms of what we have as standard treatment and what are some of the newer treatments that have emerging data for, and starting with small cell lung cancer. So for small cell lung cancer, we generally classify it into limited stage and extensive stage. Limited stage is where it's limited to the lung and potentially some lymph nodes, whereas the extensive stage is where it has potentially spread to other parts of the body, other organs. For limited stage small cell lung cancer, our treatment is generally a combination of radiotherapy and chemotherapy. In selected cases, surgery may potentially be an option, although this is not necessarily a standard option for limited stage small cell lung cancer. Sometimes after radiation and chemotherapy, there may be radiation to the brain as well to prevent spread to the brain. For extensive stage small cell lung cancer, our treatment is generally chemotherapy, drug therapy, in combination with immunotherapy. Sometimes we may also consider radiation, depending on the response to treatment and depending on where in the body the cancer may have spread to. But if we look at limited stage small cell lung cancer, in fact, just recently there has been some results from trials that have been presented that have actually demonstrated benefit for immunotherapy in also limited stage small cell lung cancer after the completion of chemotherapy and radiotherapy. I won't go through the specific drug names, but just to, I guess, emphasize that immunotherapy is now potentially going to be a standard treatment for limited stage small cell lung cancer as well. What about extensive stage small cell lung cancer? Well, immunotherapy became standard treatment probably around 4 or 5 years ago now. But unfortunately, we know that many cases the cancer may start to grow and spread again. So if the cancer does start to grow and potentially the initial chemotherapy has stopped working, there are new treatments now. There are newer chemotherapy drugs as well that have been approved in the past few years, particularly a drug called lurbinectedin. And again, even more recently, even only in the past few months, there's other immunotherapy drugs that have been approved in the US at the moment. They're not yet approved here in Singapore, but potentially can be available through special access schemes and pathways. And in particular, this immunotherapy that has been approved for extensive stage small cell lung cancer is a different type of immunotherapy. It's what we call a bispecific T-cell engager, but essentially it means that it actually will activate the immune system to try and fight the cancer. Rather than unmasking the tumor, this particular type of immunotherapy tries to activate the immune system. So I'll move on now to non-small cell lung cancer. And again, there are different treatment options depending on the stage of the tumor. We have stage 1 to 3A non-small cell lung cancer, where our treatments are generally with curative intent to try and cure or eradicate the tumor or cancer completely. And typically, local treatments such as surgery or radiotherapy are the mainstays of this curative treatment. But we do have there is a role for what we call systemic treatments or drug treatments to also try and prevent the cancer from coming back in the future. And typically this may be with chemotherapy after surgery or after radiation treatment. Sometimes there may be radiation after surgery as well. There is, in the past 5 years, data that demonstrates some targeted therapies for certain mutations, such as EGFR, may also have some benefit, as well as immunotherapy for patients without certain mutations, such as EGFR. For stage 3B lung cancer, non-small cell lung cancer, where it may have spread to certain lymph nodes within the chest, typically our treatment, and this is where potentially surgery may not be possible to remove the cancer completely, our treatment is generally considered with radiation plus chemotherapy concurrently. And again, around 5-6 years ago now, immunotherapy after concurrent chemoradiotherapy became standard treatment for 12 months after chemoradiation. The stage 4 lung cancer, where unfortunately we may not be able to cure the cancer or eradicate the cancer completely, our mainstays of treatment are drug treatments. And again, as it was outlined on previous slides, this depends on whether there is the presence of a targetable driver. So that's where targeted therapies are generally used. Chemotherapy has been the backbone of treatment historically and may still have a role in even with the presence of a targetable driver. But there is this obviously role for immunotherapy, particularly in patients without a targetable driver. But again, what are some of the newer treatments which have become available or which will be available in the near future? And in particular, there is this emerging treatment paradigm where patients without certain mutations in EGFR or ALK, for example, there is actually evidence to suggest that if we give chemotherapy with immunotherapy before surgery, as well as after surgery, this can lead to better longer-term outcomes, better chances of cure. So this is an emerging treatment paradigm. And this can be for a number of reasons. If we give treatment before surgery, potentially it may shrink the tumor, it may get rid of what we call micrometastatic disease, microscopic cancer cells that we can't see on scans that may be elsewhere. If we give treatment earlier, potentially this may be able to get rid of these cancer cells before the surgery. But also for patients with EGFR or ALK alterations, as I mentioned, there is the role for targeted therapy. In particular, recent data in the past 6 months for alectinib in ALK rearranged early stage lung cancer has demonstrated survival benefit. So there is this changing paradigm where many of these treatments are now also being used in what we call early stage cancers as well. For stage 3B non-small cell lung cancer, again, just very recently, in the past month or two, there has been data presented from trials demonstrating there can be benefit for targeted therapy for EGFR mutations after chemotherapy and radiation. Typically, for patients that may have EGFR mutations, they may not necessarily be suitable for immunotherapy, but there is now trials showing that EGFR targeted therapy may have a role after chemoradiation as well. And for stage 4 lung cancer, there are, in fact, many new therapies which are being approved, as I mentioned, almost on a monthly basis. These can be a range of types of treatment, whether it be targeted therapies, chemotherapies, or immunotherapies. I won't go into too much detail, but there is now emerging roles for combination therapies, where previously we may have given targeted therapies by themselves as treatments. We can potentially combine them with chemotherapy to improve the efficacy of treatment. And potentially we can even combine all 3 classes of treatment together, targeted therapies, chemotherapy, and immunotherapy. So really just demonstrating that there is this changing science, a lot of new evidence that we're improving our treatment options that we have for lung cancer. So in the last few minutes, I'll also just move on just to talk a little bit about clinical trials and just to set the stage again for clinical trials, in case people are not so familiar with how we develop drugs and test drugs. We use clinical trials as our way to demonstrate that these treatments are in fact safe and effective. So when we think about trying to develop drugs for cancer, they obviously go through testing. Initially, it will be done in the lab. And in fact, there may be thousands of compounds which are tested for treatment for cancer. From many thousand compounds, maybe a few will be selected for further experiments. And even from there, only a small number of compounds may actually then be tested in clinical trials, being tested actually in patients. And we can see from this figure that, in fact, this process may take many years, even up to 10 years, sometimes longer. Sometimes it can be shorter, but we can see that this is actually a long and arduous process. And in fact, we can see again on the bottom that it can be a very expensive process. A lot of experiments and trials are in fact very expensive. And even once the drug is approved, further testing or further studies will be done just to look and make sure that these drugs are still safe, that there are no other less common side effects that we haven't detected in the trial. So what are the different phases of clinical trials? Well, there are phase 1 to 3 that we generally think of before a drug is approved. Then a drug may get regulatory approval for use in standard treatment. Phase 4 is where it's studied after it's been approved, as I mentioned, to look for potentially unknown side effects. But phase one trials are generally where the drug is first tested in a trial. Generally, this may be a small number of patients or people, and this is actually to establish the right dose of the drug and to understand the side effect profile or the safety profile of the specific drug or combination of drugs. So some patients may have, seen our phase one clinic here that we have at NCCS, where we have quite a number of phase one trials testing new drugs that may have only just been developed in the lab or been tested in animals, but we are now just starting to test them in patients. Phase two and phase three trials are where we're actually trying to see whether the drug is effective. For phase two, it's historically considered as trying to look for a signal of efficacy. Typically, this will obviously involve a bit more patients, a few more people compared to phase one trials. And as shown here, it's to see whether the new treatment is effective. But once we get that initial signal of efficacy, it then may move on to phase three trials. And typically, phase three will be randomized trials. Sometimes there may be a placebo as well. And this may involve many more hundred patients. Some trials can even involve up to thousands of patients. For cancer drug trials, generally, they may involve a few hundred. But this is actually to compare the treatment against the standard treatment, because only by a randomized trial where there is one half of patients that get the standard treatment and the other half potentially get the new treatment, can we really generate the evidence that's required to see whether the drug is actually effective. But I'll perhaps mention that this is a historical paradigm, is changing a little bit. Obviously, we don't want to wait so long for trials to be done, for drugs to be developed. So there are efforts in terms of trying to improve the efficiency of this process. Trials, are being combined where phase one, phase two trials are being done together. Phase two or phase three trials may be done together. We're trying to look for efficacy signals, even in phase one trials. So this is changing, but this is the general historical paradigm of clinical trials. And what actually happens during clinical trials, so I'll just run through this very quickly, but there is actually a fairly standardized process if patients are to join clinical trials. It may start with what we call pre-screening, and this can entail a number of things. Obviously, your clinician, your doctor, oncologist may identify whether you may be potentially suitable for a trial. But again, particularly for lung cancer, additional testing, what we call pre-screening molecular studies, where we do need to do some additional tests on patients' tumors or cancers to see whether they may have a certain marker, certain mutation, because obviously there may be drugs that are being tested in trials that target particular markers or target particular mutations. Once patients have been deemed potentially eligible for the trial, they then need to consent for the trial. And the main thing to emphasize is that trials are testing new treatments. They are not proven treatments yet. That's what the trial is there to do, is to prove whether the treatment is safe or effective. And so patients do need to consider that they are potentially consenting for experimental treatment. And it's not for everyone. And you have to be comfortable with the clinical trial process and the potential treatment that you may receive. But once patients are comfortable, they will sign a written informed consent that they're obviously willing to undergo or be involved in the clinical trial. And then there will still be the screening for eligibility. So each trial will have eligibility criteria that patients have to meet to be able to start treatment on the trial. And sometimes, again, we may need to do some additional tests, scans, blood tests to see and make sure that patients meet all of the criteria, eligibility criteria to start on the treatment. Once patients pass the eligibility criteria and are happy to enroll, then they can start on the treatment itself. But even then, there will be very specific study procedures and follow-up that needs to be followed. There will be a study protocol that will guide us in terms of when patients need to come for treatment, come for visits in the clinic, have blood tests and scans done at certain time points as well. And again, just to emphasize that enrollment on clinical trials is voluntary, and patients can withdraw at any time for any reason. So there's no obligation to necessarily continue on a trial, even once starting on a treatment. It is voluntary because we know that ethically and morally, these are experimental treatments, and obviously patients have the right to make their own decision about their treatment. So they are voluntary and can stop at any time. Of course, if the treatment is not working as well, generally we would stop the treatment. If there are major side effects, we would stop the treatment as well. And again, there will be certain procedures that are done, once stopping treatment. So that's just the process of a clinical trial. What trials do we have available at NCCS? Well, we have, in fact, quite a number of trials. And if we think about all cancers altogether, there are many trials, perhaps even over 100 different trials. It spans from phase 1 to 3. There will be different trials, targeted therapies, immunotherapies, chemotherapies. Obviously, there will be trials that are testing treatments that are given in first-line treatment versus later-line treatment. And of course, there are new trials that open all the time, as well as our ongoing existing trials. Obviously, trials can close as well. And I won't go through too much detail into all the specific trials. There are obviously too many to list. They are actually, in fact, listed on our website as well, so you can, look through the website for further details if needed. But again, if I just, show this pie chart again, showing the different oncogenic driver alterations, obviously in gray, potentially patients that do not harbor any of these alterations as well. I'll just list some of the trial names just for reference, but there are trials for drugs targeting NTRK, BMIN and BI. The BI trial is targeting HER2. We've got trials targeting ROS1 and ALK, trials for KRAS, as well as trials for EGFR exon 20. These are trials for EGFR exon 19 and L858R. And these are trials for patients without any of these driving mutations or alterations. So just demonstrating that there are a range of different trial options. Of course, not every patient will necessarily want to join a trial. Not every patient will be eligible for a trial. The trials may be done for, as I mentioned again, first line versus later line treatment. So it is important to obviously speak to your oncologist, your doctor, as to whether or not what trials are potentially available and whether they're suitable for you as well. I just wanted to finish off. This will be the last sort of section, but also just to mention lung cancer screening. So we talked a lot about obviously diagnosed lung cancer treatment for stage 1 to 4 lung cancer. But there is this, in fact, evidence for lung cancer screening. So we know that there are studies that have been done that have shown that using a low-dose CT scan for patients without known lung cancer, if we screen them, we can actually detect lung cancer early. And obviously, if we detect lung cancer early before it has potentially spread, we can potentially increase our chance and rates of cure of lung cancer. So there are some standard guidelines. In fact, certain age groups. Generally, at the moment, it's limited to people that have a history of smoking. Certain quantity, pack year history, we call it, of smoking. And there is some evidence that if we perform screening using CT scans, it's actually cost effective in terms of as well detecting, diagnosing and treating lung cancer. But how about in Singapore? Well, in fact, at NCCS, we do have a study, in fact, you could call it a clinical trial called Solstice of lung cancer screening. So this particular study, obviously in our population here in Singapore, we have slightly lower rates of smoking compared to many other parts of the world. And, again, as mentioned, that geographical variation of higher rates of this EGFR mutated lung cancer. So this particular study is looking at patients that have, the eligibility criteria listed here. And importantly, there is this subset that will be eligible for this study if you have a family history of lung cancer within a first or second degree relative. So, of course, for our patients, potentially family members may be eligible for this study. So this study will include low-dose CT scans where we obviously screening for to potentially diagnose lung cancer. There will be other aspects in the study, blood tests and questionnaires as well. So obviously the QR code is listed there. So again, if anyone is interested to potentially be involved in this particular study or trial, can obviously look at the QR code. There will be certain questionnaires to complete to see whether you're potentially eligible for this study. But I'll finish there, and I'll just again show this slide of Paul Kalanithi and when breath becomes air. And I think hopefully I've given just a brief update on some of the newer treatments that have become available, some of our clinical trials as well. So obviously we'll be happy to take questions as well.
Thank you, Aaron, for that very, very insightful talk.